Welcome, everyone. I am Patty McCormick, the Senior Program Director for the National Kidney Foundation, serving Northern California, Oregon, and Washington. Thank you for joining us this evening. We're grateful to our speakers, our moderator, and of course, all of you for joining us. Having this virtual forum has allowed us to engage speakers and attendees from near and far, a huge benefit to our community. And we are looking forward to once again having in-person programs, so stay tuned for those. A little housekeeping, just a couple of reminders. If you're typing into the chat box, make sure you select everyone in the drop-down menu. That way, any comments made or questions asked can be seen by all. Dr. Zhang will be moderating the Q&A session at the end of each talk. You may also unmute yourself and speak up to ask questions during that time. I want to share our upcoming programs. The links to share this information and to register will be put in the chat and or in the follow-up email. Just as March is Kidney Month, May is Mental Health Month. To highlight the importance of that issue for the CKD community, we're hosting a patient and community webinar on that topic in partnership with CareDx. We'll forward the registration for that in the follow-up email, and please share this opportunity with your patients and network. Our next Journal Club is Thursday, August 25th, topics and speakers still in the works. We're excited to announce that our 2022 Kidney Walk will be in person, and we'll bring together all three Bay Area walks into one location in San Francisco this year. Mark your calendars, Sunday, September 18th. And save the date for our 54th Annual Medical Symposium, Friday, September 30th, in person at the Crowne Plaza, Foster City, same location as before 2020. It is now my pleasure to introduce my colleague, Amy Hewitt, the Executive Director for our region. Amy has led our team through the pandemic with creativity, an ever-evolving vision, and compassion. I count myself fortunate to be on Amy's team. Amy, take it away.
Thank you, Patty, for that very, very kind introduction. And thank you all so much for joining us this evening. I'm Amy Hewitt, Executive Director. This was me just a little over 6 weeks ago. I celebrated my third NKF work anniversary and National Kidney Month by donating my right kidney to benefit this amazing young man, Wilson Dew. I was part of a 4-period exchange at UC Davis, and I am beyond grateful for this miracle of modern medicine that allows donors to help people like Wilson and the others. I am equally grateful to all of you who care for our community of patients every day and helping them along this journey. I now have a new perspective on just how life-altering it is, and so I have my most deepest heartfelt gratitude for all of you and the work that you do. So I am also honored to thank tonight's presenting sponsor, Satellite Healthcare. We are deeply grateful for their support and partnership. The healthcare team members at Satellite start by getting to know each patient as a person. Understanding what's most important to them. Then they help individual patients understand their options so that they can make decisions for improved health and well-being. At Satellite Healthcare, patients have a trusted partner ready to help them live a better life. Next slide. Now it is my absolute pleasure to hand this over to our chair, Dr. C.J. Zhang. Dr. Zhang has been leading our effort in medical education for several years, stepping up and doubling down during the pandemic to make sure we gather and learn together. Thank you so much, CJ. His energy and creativity has buoyed our team, and we are so grateful. So welcome.
Thank you, Amy. First, I would say we are very grateful to you for all the work you do, and also being the angel of this world to donate your kidney. It's not, I always think the donors, people always use the word altruistic donor. Every donor is altruistic. You are such a wonderful person. We are very, very grateful to you. With that, I really appreciate all three speakers tonight. They donate their time, expertise to teach us this one very important subjects in nephrology, and this is the part I love the most. Besides taking care of patients, is meeting all these smart people and learning from them. So looking forward to tonight's program. And our first speaker is Dr. Rami Hanna, and he graduated from UCLA, was in molecular genetics, and then he got to obtain his MD degree from UCSD. After that, he had his residency fellowship at the Olive View UCLA internal medicine program. Then he practiced in Cedars-Sinai until 2015. Then he joined the UCLA. In 2018 or 2019, he joined 2019. He joined the UC Irvine, and currently he's the fellowship program director. He is an expert in complement disorder, participating in clinical trials and clinical research, and is building a regional and the statewide expertise in glomerular disease and onconephrology and UC Irvine. My first interaction with him is I follow him on Twitter, and I saw he posted 3 cases of intravitreal VEGF inhibitor and TMA, and I find this is very fascinating. I talked with him. He's very nice, very grateful, agreed to give a talk on TMA tonight. So with that, it's all yours, Dr. Rana. Thank you so much.
Well, thank you so much for that gracious introduction, CJ. I believe if my fellows were here to say, oh man, more TMA, Dr. Hanna, but that's exactly why I do this. I do this because I believe that thrombotic microangiopathies are very little understood, often underdiagnosed, often ignored, often missed opportunities for therapy. And they represent truly a new frontier in autoimmune disease, vascular disease, chronic kidney disease. I remember speaking with Jonathan Zuckerman and Tony Chang, who are 2 of the renal path champions of TMA, where people would note TMA on biopsies routinely of patients with hypertension, patients with lupus, and they'd say, oh, that's interesting, there's a TMA there. Well, what is it? We're not really sure. What do you do to treat it? Well, we don't know. It's like, huh, you mean there's like this entire chapter in the renal pathology book that nobody has really written? Yes. For the longest time, the only known treatment for TMAs would be plasmapheresis. And as you and I both know, plasmapheresis is only effective really for a few types of TMA, very specific circumstances when there is some antibody to remove or some factor to replace in trans that is able to abate the progression of the TMA. With that general introduction, it is my pleasure to be here with you and to share the love of TMAs I have with you. I am going to sneak in a little bit of the intravitreal VEGF stuff there. I told CJ, don't count on it being completely non-controversial, but it's important because I personally have seen 15 cases to publication, including biopsy-proven data, and I've got grant money for a registry. But with that, we're going to start into the wonderful world of TMAs. We're going to talk about what we know. We're going to talk about what we don't know. We're going to talk about what we need to know to move forward. Let's begin. So disclosure, I do a lot of clinical trials and I speak for multiple drug companies. None of the stuff today is even remotely pharma related. There may be people from auditing from 1 or 2 companies, but I think Alexion, but I'm not sure if they're there or not. But I did want them to at least audit. But this is a completely academic, unbiased, cutting edge, above and beyond sometimes what the FDA mentions, unfiltered view of the clinician's view, the master clinician's view of TMAs and how we can pass on that diagnostic accuracy and the curiosity in addressing the phenotype and understanding both the genotypic and the trigger-related things that will allow us to recognize which TMAs can be successfully attacked and tackled. So obviously, we're going to learn how to diagnose TMAs, the differential diagnosis, how to recognize atypical hemolytic uremic syndrome from what has been called typical hemolytic uremic syndrome. I absolutely hate that designation. It's actually best called STEC-8-HUS. So Shiga toxin, E. coli, or enteroinvasive enterohemorrhagic E. coli related hemolytic uremic syndrome. There's also varieties that are caused by strep pneumo, by the way, with very similar endothelial toxin and complement activating toxin that results in a typical HUS picture. Other hemolytic syndromes, there are many of them. We just haven't looked at them quite this way yet as families of TMA syndromes. And then we're going to talk about the really ugly area. This is why I'm glad to have so many smart people here, because I'm going to practice a little humility and say, there are some things I don't know. There are people who come in with renal limited TMA. Where does that stop and where does systemic TMA begin? Where does TMA stop and where do endothelial determinants of malignant hypertension begin? Where does TMA stop and where does scleroderma renal crisis begin? These are really hard questions. I don't pretend to know the answer, but at least I'm asking the right questions, right? In the scientific method, if you're asking the right questions, you're way ahead of the game. So we're going to start with a non-complement system directed family of TMAs. So we're going to basically look at TMAs that have nothing to do with complement. So a few of those would be in the TTP family, the thrombotic thrombocytopenic purpura. I used to take great joy in showing people I knew how to break down ADAMTS13, a disintegrated metalloproteinase thrombospondin motif number 13, member number 1. Basically, ADAMTS13 is the metalloproteinase that keeps von Willebrand factor from sticking together and forming essentially molecular razor wire, the small capillaries that shreds the red cells and forms platelet clumps. Even something as simple as TTP that has been known for a while. As a matter of fact, if any of you guys are as old as I am, I guess I'm in my 40s, not old, but I remember when it used to be called TTP/HUS. I remember that designation in fellowship. This is how far we've come. But even within TTP, we now recognize Upshaw-Schulman syndrome, which is a chromosome 9q deletion resulting in genetic absence of ADAMTS13, presenting as very aggressive TTP very early on in childhood. And there are acquired forms of TTP, for which case we have cabazizumab and other von Willebrand factor blocking antibodies that prevent von Willebrand factor from multimerizing, at least preventing or reducing the burden of TTP disease and allowing time for plasmapheresis to be efficacious. Other things that have nothing to do with the complement syndrome, at least on paper. An acquired vitamin B12 deficiency can result in a pseudo-TMA picture. It presents as a hemolytic anemia, rarely with severe renal failure, but you might have some some pigment-related renal injury, obviously from the hemoglobin, the free hemoglobin that's released. Autoimmune hemolytic anemia is not directly complement related. It's related rather to antibodies, be they lupus related or related to some malignancy, right? And we can detect those antibodies, at least in the malignancy related cases, through the direct Coombs test and the indirect Coombs test. And that to us is not directly complement. But remember, most antibodies, including IgG and IgM, will fix complement. So it's complicated. It's just where complement isn't really driving the school bus. It's being driven by something else. And the important thing is that there are things besides complement-mediated TMA, and how we approach them is complex, and how we think about them is complex, and the role of complement modification or blockade in them is also complex and evolving. So this is from our paper in Current Opinion Nephrology and Hypertension, and it was something very similar, was recreated with permission for ACKD. Dr. Javeri and I were fortunate to be invited to write a grand review of TMA syndromes. And these are basically some of the more common TMA syndromes we're going to see. We mentioned, of course, TTP and vitamin B12 deficiency. Those are panels A and C. And then panel B is something a little bit different. And what panel B is going to represent is your STEC-HUS, or Shiga toxin, or pneumococcal endothelial toxin related typical hemolytic uremic syndrome. Again, I hate that moniker. And I did something about it. We'll talk about what I did about it later. But the reason that we include this panel is because the Shiga toxins 1 and 2 encoded in a plasmid on E. coli are actually the toxins that result in endothelial cell death and damage, which results in uncontrolled complement activation, which also is then also activated, complement is also activated by Shiga toxin 2, I believe, which results in a very systemic hemolysis TMA-like picture. The difference is because there's an organism doing it, treatment is supportive until the body can eliminate the organism, with certain conditions where people have tried other therapies. This includes plasmapheresis and complement blockade. But at least according to the FDA, we're not supposed to do that. And the studies are not uniformly positive. They haven't really been studied in the States, but it's been studied in Europe. Unfortunately, one of the recurring themes we're going to hear about tonight is how far ahead France, Germany, and Spain are of the United States, and even England. And well, we love our European partners, but you know, we should be in charge at least we should be making more headway here. And then panel D is going to be the famous atypical hemolytic uremic syndrome, which is a diagnosis of exclusion after we have excluded the other entities. Now, before we get into the nitty gritty of AHUS diagnosis, because since AHUS is the most algorithmic of the four, how do you tell if a TMA is present? Well, typically you have thrombocytopenia with either platelet drop of over 25% or platelets below 150,000, systemic manifestations, we'll talk about the end organ effects, a hemolytic anemia, and very often renal failure. Renal failure is going to be very sensitive. Now, it isn't as severe in some TMA as in others. So for instance, atypical hemolytic uremic syndrome tends to present with much more severe renal failure, whereas TTP tends to be more mild. Whereas acquired vitamin B12 deficiency rarely presents with very severe renal failure. Whereas inborn errors of vitamin B12 deficiency create a true TMA that tends to cause more severe renal failure. So this is something that clinically you have to feel out. And since we're in a comfortable academic spot here, I feel much less restrained than I do with industry talks, because I feel like I can share with you my experience, because I've seen all these cases. I've made this my life's work, and people have been more than happy to send me interesting cases, for which I'm eternally grateful and will remain grateful if you guys want to continue to send them to me. Symptoms that you might include in the TMA buffet, if you will, include confusion, seizures. This is actually more severe in TTP than AHUS, but can be seen, and you can see it in STEC-AHUS as well. Gastrointestinal symptoms. Diarrhea is not a diagnosis of typical / STEC-AHUS make. It does not, because you can have clotting in the small vessels, the microvasculature of the gut. You very well can have diarrhea from that. Visual symptoms, visual loss, serous retinal detachment in particular is very pathognomonic for AHUS. Pulmonary symptoms across the board, it can range from dyspnea, pulmonary edema, or very scary pulmonary alveolar hemorrhage, which can be rapidly fatal. And this is a nice little slide I had made for my fellows. It was nothing that was truly publishable, but it was something I kind of put in that helps people think about what the target organs are: the eye, the brain, the lung, the heart, the gut, the liver, and the kidneys, of course. And the kidneys, of course, being profoundly affected in more severe cases of uremic syndrome. And well, why does this happen? Well, because complement, right? So complement is 3 doors, 2 amplification points, and 1 kill switch, 1 terminator switch. So the 3 doors are the classical pathways. Again, remember the antibodies are aided and abetted by complement and sort of driven by it. Complement is not part of the adaptive immune system. It is part of the innate immune system, being somewhat like a cudgel and not the smartest system. But it definitely follows antibodies' leads, and it turns the blood into a killing field for organisms that don't belong there. Lectin pathway. So if there's some like a glucopolysaccharide or a glycolipid or protein, glycosylated protein that doesn't look right, the body says this looks too much like bacterial protein. The mannose-binding lectin will bind to it and then will literally activate complement and kill it. And of course, self cells have things like MCP and other non-self determinant protective proteins that turn off complement, delay accelerating factor, but that doesn't exist on fungus and bacteria, so they die. And viruses, of course, right? Viruses, we're in the new age of viruses now. Alternative pathway, however, is the real interesting part here, because alternative pathway is sort of like what I call it's like a hand grenade that removes its own pin. So the alternative pathway results in spontaneous hydrolysis of C3 into C3A and C3b. And the way complement works is once you have C3b, you can activate a C3 convertase, sometimes with factor B, sometimes you do it in classical pathway with C2 and C4. They're nonetheless all C3 convertases. And what happens is that they then accelerate the degradation of C3, and lo and behold, you get more C3b. Now you have a C5 convertase. Then you crack C5 into C5a and C5b, C5a and C3ab aflatoxins. C5b is the nucleus around which the MAC forms. And what the MAC is, it's the membrane attack complex, and it's literally a pore, a dumb pore that will just go to anything near it that can't stop it and kill it. and it's vicious because the blood is full of this stuff. I would say complement is one of the things that makes the blood alive, an organ, in my opinion. It's able to respond to stimuli. So non-atypical hemolytic uremic syndrome, nonetheless, thrombotic microangiopathies. We'd look at STEC-HUS, which is formerly the disease formerly known as typical HUS. Then paroxysmal nocturnal hemoglobinuria. PNH is not exactly congruent with a TMA, but there is a very similar process. And what that is the loss of the glucophosphatidyl'inositol anchor that results in clones of red cells that are ripe for complement destruction. And then the complement destruction that occurs then results in anemia, transfusion dependency, pigment injury to the kidneys, long-term and other end organ effects, also thrombophilia because of this turnover. And it's not the atypical hemolytic uremic syndrome. It's not any of the other TMAs, but it has a close kinship with them because this is a complement-dependent process. So these would be best called non-atypical hemolytic uremic syndrome, nonetheless complement-mediated TMA or TMA-like processes. And the reason I'm doing this is I want us to start thinking always about the pathophysiology of a particular entity, rather than just say, well, you know, we can group them this way or that way. We should really group these entities by pathophysiology. And this is going to get even dicier when we start talking about more middle of the road TMAs later. We have a lot of work to do. So again, some of the things that also approach TMA and their complexity and their mechanisms of pathological action include C3GN, that's panel E, and then panel F would be your PNH patients, where you have the GPI anchor loss that results in clones of complement vulnerable cells. Of course, the other things we would kind of look at here is DIC, that's panel G. DIC is very different in a sense that it does involve complement, but also involves the coagulation cascade. Now, without seeming that this is a hard differentiating point, just be aware that complement speaks to coagulation through plasminogen and thrombin. So yet again, we've been foiled in our attempt to come up with completely strong walls. TMAs are very frustrating syndromes for splitters. It's also frustrating for lumpers. There's truly a need for deep pathological understanding and an agility of thought to deal with these diseases. And then one other things that we wanted to mention is there's other endotheliosis, renal limited TMA, post-HSCT transplant, post-HSCT TMAs, where they have some overlap with complement-mediated TMAs, but also differences. For instance, renal transplant rejection is usually antibody-mediated, and that can result in vasculitic changes, or actually vascular necrosis. COVID-19 and other viral infections have demonstrated renal limited TMAs about 20% of the time for COVID-19. VEGF imbalance, especially VEGF depletion, things like preeclampsia and eclampsia in the natural side, and in the iatrogenic side, obviously we see it with intravenous VEGF depletion when we use the things like Avastin and Zaltrap or aflibercept as adjunctive chemotherapy. So the point is, the difficult part is panel H. Panel H can look a lot like a systemic TMA, but it can also have absolutely no detectable systemic hemolysis or any of the typical findings and organ findings except renal loss and renal dysfunction. So the universe of TMA grows. There was one panel in my first current opinion paper. Now I think I have 4 or 5 panels, just thinking of all the things that our patients go through pathophysiologically and how to tie all that together, and then how to use nomenclature. I'm proud to announce that in collaboration with various other coders and at the behest of multiple industry sources, I actually have lobbied to have the ICD-10 code changed to give atypical hemolytic uremic syndrome its own ICD-10 code. We succeeded. It's actually been amended recently. So that's a big win for researchers, outcomes researchers, and people who are looking to move the nomenclature discussion, the discourse forward. So one thing I did want to mention is everything affects the endothelial cell. An endothelial cell, in the end, is the genesis of these TMAs. For instance, with E. coli, and with Shiga toxin encoded plasmids in enterohemorrhagic E. coli, we see this. We think, oh, it's STECH-E2S, it's the E. coli, but really it's the complement dysfunction caused by the Shiga toxin that are encoded in the plasmid. And that's really what we're dealing with. So that's why when we talk about TMAs, it's very important to talk about the trigger and the mechanism of action, but to understand ultimately the targets are going to be the endothelium and complement. And C3GN is a very interesting disease. It is not technically a TMA, but it is a complement-mediated process whereby C3 deposition over the long term mimics a sort of slow AHUS type picture. The way I describe it to people, it's as if your atypical hemolytic uremic syndrome gets slowed to a crawl. And when it gets slowed to a crawl, that's when you start seeing these changes in the patients. And people with C3GN, they can have variable differences in how they present. Some people with C3GN present very rapidly. Some people have C3, C4, and C5 nephritic factors. They present very rapidly and aggressively as well. And they may have different therapeutic considerations for plasmapheresis. Plasma exchange, and rituximab, in addition to other things like MMF and C3 blockers and even off-label C5 blockers. And C3GN is very interesting because we finally figured out the idiopathic MPGN, where the C3 to IgG ratio is more than 2:1, often is an occult case of C3GN. It's a complement-mediated disorder, but it doesn't look quite like AHUS. You don't have the very devastating rapid onset, you don't have the systemic manifestations, but when you look at the dense deposits and you look at the trend tracking, there's definitely a TMA going on there, and we know that this is due to C3b deposition. And I think it's just important to mention that it can take on a lot of different pathological forms. The key thing being it will always be either sole C3 deposition or a C3 greater than IgG deposition with a 2:1 factor that clues you into the diagnosis. This is one of the papers I wrote earlier in Frontiers, where we described several cases that demonstrated that C3 dominant footprint of C3 IMPGN. So I did want to mention that with complement blockade, we have used it in C3GN. Some cases succeed, some cases don't. And I see that's why we put but not uniformly. It's not the best agent I can think of. There are other agents now being trialed that actually will block C3 directly, and those I think are going to be much more useful, and that's why I'm running trials on that particular C3 blocking agent that's being trialed right now in the United States. I guess I don't want to say too much more, but I think you guys are aware of the Compstatin molecule in Europe, which we're now on adapt here in the United States. And again, it finally gave us some great insight that MPGN is not just going to be myeloma or hepatitis. It can also be a TMA type presentation, often, or C3GN. And that's why I'm saying there's a kinship here, because there's a thread that weaves these diseases together, and that's complement, and also the endothelium, where we see these deposits in subendothelial space. We talked about this. We have a lot of slides I want to keep moving. So finally, we get to atypical hemolytic uremic syndrome. Now, the reason I want to spend some time here isn't because I have a clinic with more than 20 patients, or I'm getting my 4th patient off dialysis this year with treatment for atypical hemolytic uremic syndrome. This is a bear of a disease to diagnose. This is not an easy disease to diagnose. And we can recognize it in boards, but the problem is life isn't the boards, right? Life is always more complicated. So it is a historically overlooked common end phenotype of uncontrolled complement activation in genetically susceptible individuals, though you might not always find the mutation. Only 60% of mutations are known right now. That occurs due to a very large number of environmental triggers. And it begs the question, is arose by any other name just as sweet? Because there's a lot of people who look at these diseases and say, well, this is a drug-induced TMA. This is a malignancy-induced TMA. But HUSs have a specific footprint. And we have to pay attention to that, because we might be having diseases that are treatable that are hiding behind the triggers that induce them. And so we have a cure hiding in plain sight for these patients. It's distinct in ADAMTS13 deficiency, TTP, namely in pathophysiology, but similar in clinical appearance, can be induced by mutations in the alternative pathway or by autoantibodies. Autoantibodies can basically mimic almost any genetic mutation you can think of. Activating antibodies, blocking antibodies, or antibodies that increase clearance of a protein can all mimic a genetic absence of a disease. So that means that we can have even autoimmune flavors to these sorts of presentations. And the biggest thing we look for is the presence of schistocytes. It's helpful when it's there. It's not always there, but I certainly have had my fellows go down and talk to hematology often and make sure they do a peripheral smear and stick it in the chart so we can admire it. We need a little more heme at UCI, but we have some people there. And it used to be that we would say, well, just rule out STEC-HUS and TTP and you're done. But now we have a lot more things I want people to rule out. I want people to consider PNH, autoimmune hemolytic anemia, catastrophic antiphospholipid antibody syndrome, at least that has a different therapy up front. Sometimes, there might be complications involving complement despite that therapy. C3GN need to be considered. Acquired and congenital and autoimmune related TTP need to be considered. And vitamin B12 deficiency needs to be considered. STEC-HUS or pneumococcal HUS need to be considered. This is progress, because when we really had to rule 2 or 3 things out, and then we say, well, this is probably HUS. Now we have a lot more considerations of things. So, hey, well, is this really HUS? The signs, the cardinal signs are a rise in the LDH. Schistocytes are helpful when present. Low haptoglobin is helpful, but not always present, unfortunately. An elevated reticulocyte is telling. But by far, the most severe phenotype that we need to keep an eye on is the inexorable renal failure we see with atypical hemolytic uremic syndrome. Something like 25-to-1 increased risk, creatinines above 1.7, 2.3, based on the Joubert and Coco papers that somebody's going to be having atypical hemolytic uremic syndrome as opposed to TTP. And I think the important thing is when we have the diagnosis, then we treat to the diagnosis. If somebody has vitamin B12 deficiency, we fix that. If they have a congenital B12 mutation, well, that's tougher. You try chemical therapy and, we don't have gene therapy yet. So that might be a tougher thing to deal with. TTP, you do plasmapheresis. You might need rituximab if there's an inhibitor, acquired TTP. If you have a disorder like atypical hemolytic uremic syndrome, the gold standard is going to be complement blockade. Unfortunately, there is really no data long-term, especially for the use of plasmapheresis in atypical hemolytic uremic syndrome. Some folks in France will tell you that you provide a little bit of complement factors and patients say with like a particular deficiency of a protective factor that help in trans, but it's just not sustainable because in these people, 50% of them will end up on dialysis in 5 years without some therapy to interrupt complement disorder. And again, the complement system, I just wanted to take a moment and remind you guys that from this system, a lot of things can go wrong. I wanted to also tell you not to ignore the effects of C3A and C5A. Both of these bad actors, even though they're not directly involved in progressing the complement system, are anaphylatoxins, and C3b itself is also an opsonine. So a lot of other inflammation that occurs when complement is activated. Triggers. Now, here's the interesting thing. We know that about 70% of patients will have a known trigger. 30% will not. The numbers are actually 69 and 31%, but I wanted to round them up for easy mathematical retention in the future. And you see, this is the only disease that there's so many other diseases that feed into it. I mean, this thing is like a mutation of a disease. You have a disease and, you're already struggling with lupus. And next thing you know, hey, we've hit you with MMF, we've hit you with voclosporin, we've hit you with Benlysta, we've hit you with Cytoxan, and nothing is improving anything that has to do with a systemic TMA with hemolysis and other systemic features. And everybody's saying, well, it's the lupus. Well, you've already beat the lupus to death and it's not getting better. You start to think about a TMA complicating lupus. You start to think about a TMA complicating antiphospholipid antibody syndrome. Many pathologists have opined that CAPS has a complement component. And I've seen a case like that was easily reversed. Nothing we did for the APLS work, but complement blockade actually worked. We're going to discuss this case in a hurry. Pancreatitis can do this. B12 deficiency can do this in a mild way in an acquired patient, in a severe and actually in a way not really responsive to complement blockade in patients who have inborn errors of metabolism. Transplant can do some of this. and it overlaps very, very closely with transplant rejection. Not saying you can treat transplant rejection with complement blockade, but some of the same changes you can see pathologically. And there have been cases reported that for the whole world seemed like complement just did its own thing. Why does this happen? Well, because just like autoantibodies are a derangement of the immune system, complement disorders are a derangement of the immune system. You just need somebody with enough genetic mutations to reach critical mass and across the TMA threshold, and then to propagate that TMA, and then the TMA occurs. And now you've given birth to something truly frightening, a disease that you can't stop in its tracks, even by stopping the original disease. Case in point is pregnancy, right? Some of the other triggers we talked about, but pregnancy is a very well-known one. And on a personal level, it happened to a family member of mine. A family member of mine developed preeclampsia, delivered, didn't get better, got worse, developed peripartum TMA at this point, kept being called preeclampsia/HELP. Even a week after, and the patient was on dialysis, and they're like, "Oh, well, she developed preeclampsia and she delivered the baby a week ago." You deliver the baby, you terminated the problem that was causing preeclampsia. Preeclampsia, we know from the work of Dr. Ravi Tadani and others, Kara Munshi, Cedars-Sinai, formerly from Harvard, that involves the SFELT1 protein that scavenges VEGF and with anti-endothelin toxins from the placenta that then go out and cause havoc in the endothelium of people's blood cells and blood vessels. And when you deliver the placenta, that's gone. But if you have somebody with a CFHR 1 to 3 deletion, a factor H mutation, a factor B mutation, the body is so sensitized that complement is not very well stabilized. Complement needs a good safety. Complement is, like I said, an explosive material, almost like nitroglycerin, that propagates without mercy. And in people without that genetic good safety, it can cause a lot of damage awfully quickly. Again, the genetics we wanted to mention, I kind of stole my own thunder. There are mutations that reduce cellular defense against complement activation. That's factor H, factor I, MCP, thrombomodulin. There are mutations that cause greater complement activation. So reduced inhibition or greater propagation, they're both the fuel that causes the fire that is complement disorders to rage on. Atypical hemolytic syndrome associated mutations are many. There can be loss of function mutations and gain of function mutations. We mentioned earlier that autoantibodies can do almost anything a genetic mutation can do. After all, genes work by producing proteins. Anything that activates proteins incorrectly or removes them from circulation is sure to look like a mimic of anything you can do genetically. And interestingly, even things like von Willebrand factor and NMTS13 show up in genetic screens in HUS patients. Meaning, as I suspect, and as I mentioned, everybody's talking to each other. All these pathways we think are distinct in reality, in vitro, in vivo, are much more cross-communicated. And again, I wanted to mention to you this scheme, and it's important for you to see how many genes there are. Some of the newer genes people have discovered are vitronectin, ADAMTS13, plasminogen. This is very surprising. We see MCP as a major one, factor BC3 and C5, no surprise there. Factor H and factor I and thrombomodulin, these are more protective mutations that when they're gone, their effects are immediately noticed functionally in complements. And importantly, diacylglycerol kinase epsilon, DAG-KE mutations. DAG-KE is a kinase that inactivates a molecule called diacylglycerol. With that, diacylglycerol shoots up and people have a highly thrombophilic state, very highly potent TMA. These patients don't respond to the complement blockade. They have a unique subtype genetically of disease that looks phenotypically just like a atypical hemolytic syndrome, but doesn't respond to complement blockade if it's short. Again, that's important to mention because it just doesn't matter that you find a gene. Which gene matters a lot as far as prognosis, as far as whether you can stop therapy after a certain amount of time, and really whether you can stop therapy at all. The problem has always been that these are not super common diseases. Obviously, we see acquired TTP is rather rare. Congenital TTP is rather rare. Strep pneumo hemolytic syndrome is rare. Stachyhurst is by far more common in children, has a much more benign course in children. Atypical hemolytic syndrome is somewhere in the neighborhood of, they say 1 to 2 out of 200 to 300,000. So somewhere between 1 in 100,000 and 1 in 150 or 170,000. My feeling is those numbers are going to go up because I really feel people are being missed. I see too many young women on dialysis who haven't been appropriately worked on. Postpartum TMA is the one that worries me the most because our colleagues in gynecology are very rigid in their understanding of preeclampsia. And there are many wonderful MFMs who are pushing the envelope. One of them being my friend, personal good friend, Dr. Richard Berwick at Cedars-Sinai. And that is an area I think we all need to do better because these patients are in the prime of their life and we really need to fight for their kidney function. So now let's get controversial. Now that we've gone through the standard stuff, this is up until now, you've heard all the stuff that I would usually lecture on, maybe lecture the fellows on. Let's get really down in the nitty gritty and see where does AHUS stop being AHUS and where do other complement-mediated TMAs begin? Are all TMAs complement-mediated? And is TMA a common phenotype associated with physiologic aberrations? Or is it a spectrum, a dose-dependent spectrum, genetically that yields for some people to have TMA and some people to have, maybe hypertension and some people to have nothing? So we'll see. So the pathogenesis of TMA is there's a trigger and then a positive feedback loop. That positive feedback loop results in endothelial damage, clotting, red cell damage, activation of complement that then further damages the endothelium. And again, really, there's going to be other agents that modify this, be they mutations that cause an increased risk in somebody, autoantibodies, or paraproteins. And Dr. Juveri, again, I put the attribution down from Nephron Power, has been a very close collaborator and has been with us in this really grand review we're writing. And he has been mentioning that there's endotheliosis, there's more vascular angiopathy phenotypes, and then there's patients with vascular and glomerular damage. And he said there's some subtypes we can look at. He thinks preeclampsia and in anti-cancer agents, being an onconephrologist, he sees a lot, are more endotheliosis-related TMAs. More angiopathy predominant cases are seen with severe hypertension or scleroderma. Vascular and glomerular endothelial damage are with AHUS, maybe like vitamin B12 associated TMA, drug-induced, chemo-induced TMA, lupus, and cancer-associated TMA. So how do we treat these differently? At this point, nobody knows. And then finally, there is the entirely different family of TTP and antiphospholipid antibody-associated TMA. I would say that consideration of this involving complement should be given. I don't think this is completely separate, because I've seen cases of APLS that you treat with rituximab, Cytoxan, and plasmapheresis, and you don't see much of a response. And of course, one of my things I'm most interested in is what happens when you deplete VEGF. But when you deplete VEGF, the podocytes start to atrophy, they lose all structural integrity, and the endothelial cells start to die in the glomerulus. And you get a frank TMA. Now, one thing about VEGF inhibition, it is very hard to treat. VEGF inhibition-induced TMAs are very hard to treat. There are some cases that show response to complement blockade, and many cases do not. But the first thing you should do is stop the drug. And I've even seen intravenous cases of VEGF toxicity that result in nephrotic syndrome. Several cases actually look a lot like minimal change disease. And some were able to respond to intravenous steroids and other initially, and then oral steroids and other therapies. But really, even blocking complement with them is not particularly going to work, because if there's an imbalance in VEGF, VEGF is a master control molecule in the podocytes and endothelial cells, and it screws up a lot of transcription, including transcription of apoptosis proteins and RAS dysregulation. And then the other thing I wanted to remind everybody is there are VEGF receptors on the podocytes and on the endothelial cells, and that VEGF dysregulation is at the heart of everything that makes the glomerulus work. Regulation makes it work well, dysregulation makes it work poorly, and TMAs affect essentially the entire kidney. That's why they're so devastating to the nephrologist and so difficult to treat in our populations. And with VEGF, in particular, which is the more difficult type of TMA to get wrap one's mind around. It's not particularly complement mediated, but it involves complement. But there's a balance. Too much VEGF results in FSGS. It can result in worsening diabetic nephropathy. We know hypoglycemia actually is pro-VEGF signaling. TMA can result also from too little VEGF signaling. So everybody's sitting there trying to figure this out, looking, well, both are bad. But that actually makes sense, because if you have something truly critical to the human organism, we'd expect it to function at a set point model where there's a J-shaped curve, where too much results in utter catastrophe and too little results in pathology. And this is exactly what we see with VEGF signaling. And we know that there's also direct links between activation of the alternative complement pathway due to decreased VEGF. We see it in graft versus host disease. We see it in post-HSCT TMAs. By all means, these are not easy TMAs to treat, and they are not always uniformly very responsive to complement blockade. But we do know that there's two factors in these more complicated cases. There's the complement system being activated, and we know there's also VEGF dysregulation, which explains why, like Sanada Judel said, you have to really crank up the dosage of complement blockade to see an effect in post-HSCT TMA. Now, again, back to the VEGF issue, I just wanted to say I became interested in this when I saw minimal change disease after intravenous VEGF blockade injections in a patient with Cedars-Sinai with GBM. And then I saw the same phenotype in somebody who got it in the eye. And that we have the whole different lecture, but I can prove to you from the literature that these drugs are absorbed. I can prove to you from my patients, because I checked their VEGF levels way low, and I can prove to you from the biopsy. But one of the nastier and more difficult and less recognized kinds of TMA are TMA due to VEGF dysregulation, particularly poor VEGF signal. So that's important for you guys to recognize when you see patients getting cancer adjuvant chemotherapy. And I would be very happy if you look for your patients receiving drugs like aflibercept, drugs certainly like bevacizumab, and to a lesser extent, at least in theory, would be ranibizumab, because ranibizumab tends to be fairly short-lived in the eye and poorly absorbed in blood. Again, VEGF affects everything. Everything shown here. This is the glomerulus. Glomeruli are podocytes and endothelial cells. That's really all they are, with Bowman space and a little bit of space for urine filtration. And the tubules, which as wonderful, cells as they are really more like the moving parts of the kidney. They're not really the master control. The master control is going to be the podocytes and endothelial cells. And again, the bottom line I wanted to mention to you is these drugs can cause very severe TMAs. When you deplete VEGF from these cells, the entire glomerulus is choked off. And let's not forget that we also have very complex TMAs that can present as renal limited TMAs. In some cases, can present as TMAs with systemic manifestations. Let's talk about lupus, right? You have antibody-mediated rejection that has antibodies involved, lupus that has antibodies involved. And what I wanted to mention to you here is that clearly diseases that manifest with hemolysis need to be treated first. If the hemolysis gets better, then we can say that it was the trigger triggering the hemolysis. If the hemolysis doesn't improve, we have to worry about AHUS complementing something like, or not complementing, complicating something like lupus. And if it complicates something like lupus, then you have to go after the complement system. And what I wanted to say is that you really want to make sure that you always have an eye on what the patient's course has been. You have a trigger, you treat the trigger. You have a bad drug, you remove the drug. If you still are having systemic complement activation, systemic hemolysis and end organ effects and renal failure, you want to treat the complement system. If you end up in a case where just treating the trigger was enough, then you don't go after the complement system, because it's a question of whether the fire has started, whether the positive feedback loop has already started. And I want to differentiate some of the other cases where we talked about renal limited TMA. We still don't have a lot of evidence that going after renal limited TMA with complement blockade is uniformly going to be successful. But I wanted to compare and contrast these more difficult cases, including renal limited VEGF depletion related TMA, with cases where you have antibodies and then you have treated the trigger and patients aren't getting better, in which case then there's always a role to consider for complement blockade, because you're having systemic symptoms. My rule is if you see systemic symptoms, if you see a likely clinical scenario, and if there's a trigger that you've tried to treat the hypertensive urgency, emergency, and you still have hemolysis and renal failure, you have to consider whether the complement system is being activated, as mentioned in Timmerman's Kidney International 2017, I believe in 2019. Other interesting things we want to talk about is, we just mentioned this, is hypertensive emergency and urgency. How much of cases are going to be related to the sheer pressure of the trigger, and how much are going to be related to genetics and other factors? And I wanted to mention, when you look at a TMA case, on one extreme, you're going to see things like malignant hypertension, which you control the trigger, everything gets better. You're going to have things like preeclampsia, scleroderma renal crisis, where that's a more renal limited phenotype. And really the jury's out on these patients, and you treat the trigger, they get better. And then you have the sweet spot in the middle where, no matter what you do, there's complement activation. These patients are genetically susceptible. And then on the other side, you have TCP, which is a whole different pathophysiological mechanism. And the bottom line is they all involve the same actors, but there's different ratios of trigger to genetic dysfunction that result in a particular clinical phenotype. And people have even mentioned things, and I apologize for the nomenclature. The reason why I took hours and days of my time to try to fight this is because I don't like words like secondary atypical hemolytic uremic syndrome. It makes my head hurt, right? It's pain for my brain. And what we wanted to mention is the way people are thinking about it is a primary atypical hemolytic uremic syndrome and a secondary atypical hemolytic uremic syndrome. And the truth of the matter is, it's very dangerous right now saying someone has no genetic abnormalities, because we only know 60 to 70% of the genes. We're discovering new genes all the time. And I would say that we really need to sit down and take a more open-minded, curious approach to naming these disorders, and stop pretending for a second, as smart as we are, that we know everything there is about something we've neglected to study as immunologists and nephrologists for the last 40 years. So some people say that thrombi is one way to kind of try to get into ideas about what actually is causing a TMA. They would say that frank thrombosis is more common in things like CAPS, catastrophic antiphospholipid antibody syndrome. TMA that tends to be more glomerular is more like your classical postpartum TMA. There's some arterial TMA types that are thought to be more thrombotic angiopathy, things maybe VEGF-related TMA. And there are distinguishing features for each of the TMAs. But I'm again going to take a step back and say vessel size matters. What we don't know enough. We don't have enough of a TMA database. Here in the States, the TMA database is controlled by pharma. Some people are trying to change that. Not right near you guys, Brad Lewis is forming a database. David Leaf and Shruti Gupta are forming a database in the Brigham. So we need a publicly searchable, academic, independent database. As much as I love pharma and the wonderful things they've done for the community, I think us academic types need to have access to data that we control and that's not controlled by industry. And I just wanted to mention all to you is that there are families of TMAs emerging, and we see some features that are important for each of us to think about. Again, per se, Professor Dr. Ken Argyvari, preeclampsia, you see more endotheliosis. Hypertension, scleroderma, you see more angiopathy, larger vessel disease. Autoimmune diseases with TMA, you see more microangiopathy with frank thrombosis, things like APLS and lupus. And drug-induced TMA, you see angiopathy and endotheliosis. These are patterns noted by Vanessa Bajol, who's a very well-known renal pathologist who was at Harvard at the Brigham, and now she's at Northwell Health, Hofstra. And the bottom line is, lots of pathologists would challenge this and say you can't tell the diagnosis or the etiology necessarily, but I would say that at least some people are trying to make families of TMAs. May not be perfect, but we need to start really thinking of splitting them up into broad types and lumping them into similar phenotypes or similar families, because just like it was once called HUS TTP, in the future, I'm sure we're going to have many more delineations. Look how far we've come. Maybe 20 years from now, there'll be like 100 things that cause TMA, each with its own pathological patterns and pearls. Hypertension associated thrombotic microangiopathy. I just wanted to tell you guys, it's a chicken and egg problem. Is it the endotheliosis? Is it the vascular, the shear stress is a complement activation? I think the answer is a little bit of all of the above. And use of biopsies to diagnose TMA, it's often very helpful. However, it can be very dangerous in patients who are prohibitively hypertensive. You have to worry about patients who have bleeding risk if they're severely thrombocytopenic. Our IR division is a little skittish of these patients with platelets of 70,000. I wanted to mention to you that with HUS, typically you see platelet counts above 35,000, sometimes as high as 100,000 and above, whereas with TTP, it's usually much lower. So believe it or not, HUS patients are some of the people you may be able to biopsy, right? And I'm just going to show you some of the slides that you could expect to see on biopsy. These are biopsies of histological examples of TMA in various organs, lots of clot, onion skinning. You can see sometimes TMA showing up in the dermal layer in skin biopsies. This is one of my patients that I diagnosed, had a very similar finding to the panel on the right. You can actually even stain for C5-9b MAC activity if you have a good pathologist or dermatopathologist. You can look under immunofluorescence and see if there's thrombi that you can detect. That'll help you. There's even very mild phenotypes where you see mucoid change, endothelial cell death and detachment. And you can see particular features related to VEGF, VEGF depletion related TMA. These are various case reports I've shown of patients who developed TMA after intravitreal Avastin, or should use the chemical term bevacizumab. Ranibizumab has had some cases, and aflibercept, particularly the two bad actors are bevacizumab and aflibercept when you look at the pharmacokinetics. And then you can see also things like collapsing FSGS showing TMA features. You can see many other syndromes where you actually can detect TMA and paraproteinemia and other disorders. You can even see smoldering myeloma present as TMA. It's actually been added to the monoclonal gammopathy of renal significance definition. You can see it with TKIs. You can see it with VEGF blockade, as we mentioned. You can see it. This is also one of my cases. Patient had dasatinib, resulted in a TMA despite wildly successful suppression of her CML. And distinguishing, we're going to skip over this stuff because the stuff I think is all pretty simple. I would just mention to you the most important thing is just make sure that when you do the workup, you get ADAM-TS13 to distinguish your TTP from your atypical hemolytic uremic syndrome, and more severe renal failure, again, favors AHUS over TTP. Genetics and complement profiles, just some of the more new information. Be aware that you can get genetic profiles from Machion Diagnostics in Oakland. Cincinnati Children's helps you run genetics and can help you run a complement profile. Iowa and Mayo all do the same, and I've used all of these. I've even looked for C3, C4, C5 nephritic factors, autoantibodies against ADAM-TS13, anti-factor H antibodies. All of these things are available. You just have to go looking for them. And while we don't have a marker yet, I want to share with you Garvilacki and Galbacera, showing you that there's now basically tests that help you recreate these the C5 to 9b deposition in vitro that will help you know that somebody's serum may have overactivated complement. We treat with complement blockade. I don't want to take too much time to talk about that because I want to really focus on the new information. And I wanted to tell you that in cases where you actually have complement activation, complement blockade is wildly successful and effective. It does come with some risks of meningococcal meningitis, which we mentioned. And 80% of patients who, if they were enrolled within a month or two of the start of symptoms, were able to stop dialysis. So that was huge. Don't count on plasmapheresis in atypical hemolytic uremic syndrome. I don't know what to say about VEGF-related TMA. At this point, jury's out. I don't know what to say about renal-limited TMA. When we talk about complement blockade, we are talking about systemic TMAs like atypical hemolytic uremic syndrome. When we talk about plasmapheresis, we're typically talking about TTP. STEC-HUS is also, the jury is out. We don't know yet where that's going to go. And when you do treat the patient with the right modality, you usually see normalization of the hematological parameters and also normalization of the renal parameters. If you do not see normalization of the renal parameters, you want to consider, right? So if your creatinine of 1.4 isn't getting better with TTP, is it really TTP? If your creatinine of 3 is not getting better with plasmapheresis with HOS, then you know that you need complement blockade. You need to see a renal response. That's why as a nephrologist, I'm very passionate about this disease. People have even talked long-term doing things like liver transplants along with eculizumab, just to limit the duration of eculizumab, because unfortunately it's a very, it can be a somewhat cost-sensitive issue. And in addition, lifelong drug therapy is not usually something people are not fond of. Again, the American Apheresis Society says that if you're doing that plasmapheresis for a week and things aren't getting better, question your diagnosis and think about the pathophysiology. I'm sure you guys can look up eculizumab dosing. There's also ravulizumab dosing, which is weight-based. But the bottom line is there is something to use for atypical hemoglobinuria syndrome, and that it does have outcomes that are supported, and it is FDA approved. Stopping the drug has been the big problem, including when do we know when to stop it. Relapse rates can range between 2 to 5% in some populations and 26 to 30% in other populations. It all depends on the genetics. Again, another major plug for getting genetic testing in these patients. Please give people meningococcal vaccine. You have to be REMS enrolled to give complement blockade. Again, I'm more than happy to talk to anybody through writing the drug if you need it. Be aware, and I'm glad I can say that here, because I can't, it's not on label. Make sure people are vaccinated against strep pneumo if you're going to do complement blockade, Haemophilus influenza. Careful that the reports of shingles reactivation and invasive aspergillosis, though it's not something you'll hear about often. These patients are splenectomized and they're immunomodulated, but I would consider them somewhat immunosuppressed as well. And now we have the longer acting version that you give every 8 weeks or every 4 weeks, depending on whether you're treating an adult or a pediatric sized patient. And that drug has been out on the market for several years now with comparable data. I'm not going to have time for the rest of this talk because I have multiple other slides. Dr. Jen, do you think it's time to start questions and answers? I think there might be some further
I think
questions.
so. I think we are 10 minutes over. Anybody has any question, feel free to unmute yourself. I think we have time for 1 or 2 questions. We should bring you back to give us another talk.
This is a deep ocean, isn't it?
It is.
This
It's
is a deep
fascinating.
ocean. It is. And we're not there yet, but we're going to get there someday.
Okay. Yeah. I would love to hear the 4 cases you've taken people off dialysis, but for the sake of time,
yeah, we'll have to do that later.
Yeah, we'll do that later, but I will keep in touch. I actually have a bunch of questions I want to ask you. I'll give you a call and feel free to put your question in the chat box. I can convey it.
I'm actually going to do this. I'm going to give everybody my email.
That's wonderful. Yeah.
And you know what? As you can see, I love this and you're not bothering me. So call me if you need me. With that, let's make sure to make room for the other speakers.
Okay, great. Thank you so much. Our next speaker is Dr. Susan Wong from University of Washington. First time I met her was back in 2016 at the Kaiser Permanente. We have an offsite. We invite her and a group of, I think, oncologists to talk about end-of-life discussion with patients. She taught us a lot. Then following her publication and literature, she has done wonderful, wonderful work on this topic. She is currently assistant professor in Division of Nephrology at University of Washington. Susan, thank you for joining us tonight.
Absolutely. Can you hear me okay?
Yes.
And can you see a picture of a soapbox?
Yes.
Thank you. All right. So CJ, Patty, thank you so much for allowing me to come here and to share with your audience a study that we're currently conducting at the University of Washington and to give me this soapbox here. I won't be presenting a lecture, so all of you can put down your note-taking pencils and just relax. And what I wanted to do with these next 5 minutes is to simply tell you about a study that I'm tackling on caring for patients who forgo maintenance dialysis and kidney transplant, and try to convey to you the importance of this work and why I feel like why I would like you to participate. So as many of you know, we have registries in which to track patients who get dialysis and their care and their outcomes. And we have this also for kidney transplant patients, but we have no systematic way of tracking patients who reach the advanced stages of a kidney disease, but are not treated with dialysis. And so we are essentially that frog at the bottom of the well. We only have a limited view of the entirety of end-stage kidney disease. And we have an incomplete view of care practices for these patients. And I want to stress the importance of making this distinction between any patient who doesn't get dialysis and patients who deliberately make a decision to not pursue dialysis. I think the simplest analogy that I wanted to share with you is I'm a parent, and if I have two sons and one son isn't going to college because he doesn't know what he wants to do with his life, and I have another son who's not going to college because it's a deliberate decision and there's something else that he is seeking, I'm going to manage these two children differently. Sure, there's going to be overlap in the care that I provide. They're still going to live in my house. They're still going to have my maternal love, but I'm going to manage these patients manage these two sons very differently. And I think this analogy works well and translates to the care of kidney patients. And this is the only data slide that I'm going to show you. And I do this only to make a simple point. This is a study that we did at the VA where we compared end-of-life care between patients who were treated with dialysis here in the black, those who were preparing for dialysis but didn't get treated for one reason or the other in the gray, and those in whom there was a deliberate decision not to pursue dialysis. And what you can see here is the kind of end-of-life care that they received was strikingly different. So patients who were not treated with dialysis, but were preparing for it in the gray, and patients who didn't get dialysis because they chose not to, had different access to care. Patients who made that deliberate decision were much more likely to receive palliative care and enroll in hospice. So again, depending on what patients say they want, what they decide, it somehow shapes the way that we care for them. I also wanted to use the slide to make the point that it's important to track what happens to patients after they choose to forego dialysis, because it helps us understand what kind of care we're giving them and are we doing a good job. So this dotted line shows you the rates of hospice enrollment among patients in the same health system who are dying of terminal cancer. And you can see that their hospice enrollment rates are upwards of 72%, whereas they're more around 39–40% for patients who forego dialysis. So it's not clear to us, why are there these disparities in care? We know what's the eventual outcome for these patients, yet they're not accessing hospice for unknown reasons. And so this is the study that we are conducting. We are seeking adult nephrologists and advanced practitioners to complete a brief 5-minute survey to share with us their perspectives and their experiences with caring for patients who forgo dialysis. There will be questions pertaining to how often you take care of these patients and what services you provide them. And what the findings to these questions will help provide us a view of our current capacity to care for these patients. There's also going to be some fun questions about your views on the different terms or the terminology that we use to describe the care that we provide these patients. Terms from everything from conservative kidney management to non-dialysis pathway to kidney palliative care. And this issue of terminology has become a hot button issue among the community of people who work with these patients. I didn't entirely appreciate it until I started publishing in this area, and wow, people are very specific about the kinds of terms that they use and believe that it carries special meaning or influence on patients. So I'd love to hear your perspective on this. It's something that is being debated even as we try to develop clinical practice guidelines. I think trying to come up with a unified language around this approach to care is going to be really helpful for nephrologists, but also patients on the receiving end. So instead of picking up your pencils, I hope that you will pick up your phones and you will use your camera and use that QR code to go to the REDCap survey. If you include your email address in the survey, we will send you a $5 gift card as a token of our thanks for completing this survey. I also wanted to mention that you don't have to have ever cared for a patient like this to participate in the surveys. We want to know what your experience is, even if it is zero, and what your views are on this approach to care as well. So CJ and Patty, thank you so much for this soapbox, and to all of you for 5 minutes of your attention. And I am looking forward to hearing the rest of the talks this evening.
Great, thank you, Susan. I already
Susan.
finished the survey. And
I put it in the chat. I put the link in the chat, folks, too.
okay, and I encourage everybody to participate. And Susan is going to give us another talk in the coming Journal Club on August 28th, right, Patty?
25th.
25th. Okay. Looking forward to that. Our next speaker is Dr. Chi-Yuan Su. He is the Chief of Nephrology at UCSF, and he's the Professor of Medicine there. I met Chi back in 2008 when I joined Kaiser Permanente, and we are fortunately working together on the ASSESS AKI study. And he has been a good friend and a very kind person. He is the go-to person I have if you have any questions. Thank you, Chief, for willing to present this topic, very important topic.
Thank you very much, CJ, for inviting me. I really appreciate everyone's attention. It's not easy to do 2 hours of attention on a weekday evening. So I think that when CJ invited me to give a talk, I think we agreed to make it sort of informal. It's kind of a controversial topic, a hot topic in some sense, and people have very strong opinions about EGFR. Right? Every single nephrologist has strong opinions about it. So I actually would encourage people to interrupt me and to throw out questions. And maybe CJ, you can look at the chat and maybe just shout out questions. I have some slides prepared, but I'm happy to go off topic and off schedule to accommodate people's interests. Because I think that's a dialogue is much more meaningful, I think, than me sort of lecturing on the subject. So here are my slides, however we can see it. CJ, looks good? Okay, good. So I want to state up front, I have no conflict of interest to declare, specifically none with people who make cystatin C assays, who I will talk about, or creatinine assays. So I think CJ wanted me to talk, I mean, Journal Club, it's weird to talk about your own paper in Journal Club, right? But he wanted me to talk about sort of the clinical question. So I think everybody has seen patients like this, and this is just an email I found recently, just triggered by this. Is a patient of mine who has nephrotic syndrome, he's on rituximab, and he has COVID, basically, right? And then this question is like, Chi, what would you consider his GFR to be? Paxlovid is first line, but not recommended with GFR less than 30. He's right at the border. It's like 29. And then, right, so, and we encounter this frequently, right, in clinical practice. This is the Pfizer Paxlovid label, not recommended, in part because it hasn't been determined the right dose with severe renal impairment less than 30, right? And then your dose reduce when it's 30 to 60. This is another well-known example, metformin, FDA label. Metformin is contraindicated in patients with EGFR below 30. Starting is not recommended when it's 30 to 45. This is the UCSF webpage for gadolinium contrast scans. You have to make people sign an informed consent if it's GFR less than 30 for group 3 agents, which, really throws a damper on the whole thing, right? This is the guidelines for iodinated contrast. I bring up GFR less than 30 in bold and italicized. Contrast should not be administered. Of course, in fine print, it says that you should document the need, that the risk outweigh the benefits outweigh the risk. So it's doable, but it's sort of actively discouraged in some sense, right? And for many people who are at the front line of doing these things, radiology technicians and various non-nephrologists ordering CAT scans, I think it does inhibit people from prescribing these things. And of course, this perhaps is the most well-known threshold issue. This is getting on the preemptive kidney transplant wait list. This is the actual language from OPTN, which is that you get to be on accrued time if you're age over 18, and then your measured or calculated creatinine clearance or GFR is less than or equal to 20. This has often been interpreted to mean eGFR less than 20, but really it doesn't say anything like that at all, frankly. And we can talk about that later on. So clearly the clinical questions actually have been around for quite a while, but the controversies are more recent, I would say, perhaps. And the controversy is, as everybody knows, right? Recently, the two most common equations used to estimate GFR, the MDRD equation, CKD equation, has not only creatinine, age and sex, but also race in the form of African American or non-African American. And creatinine, by the way, is measured over 250 million times in the country, right, every year. It's even more around the world, right? So this is a ubiquitous blood test, one of the most common ones in clinical medicine. And I would say this is the first paper by Amaka Enya and her colleagues at Penn, who really start questioning this idea about using race to estimate GFR. I would say that before Amaka, to give her a lot of credit, there's been people talking about this, like Dorothy Roberts, but they really haven't really made it into, I would say, the medicine mainstream, that people have not thought about it. It's been concentrated among, some humanities professors, and but this is a very important article, which really spurred a lot of discussions. This is in the end of 2019, talking about abolishing race-based medicine, and this is from different lay press. And then I think a lot of things really got much higher profile, got a lot of attention after George Floyd was murdered by a police officer in 2020, right, during the pandemic. And I think that this and other similar events really triggered a wave of a racial reckoning across this country. And the GFR was held up as an example, a prime example of potential structural racism in medicine, right? And then there's a lot of high profile papers which have debated this, including this one, which pointed out that the use of race correction clinical algorithm may disadvantage those who are African American. And then there's other discussions about misrepresenting race in medical schools. Dorothy Roberts is a co-author. There's a discussion, however, this is a group of people large at UCSF about issues with ignoring race or genetic ancestry. There's also discussions about genetic diversity and how to use that to improve blood health. This is also made into the lay press. Many of you have seen, this is from New York Times. Many medical decision tools disadvantage Black patients. This is from STAT, about a year-long push to remove racist bias from kidney testing. And a lot of this was quite, close to home. So many UCSF medical students, for example, or UCSF other trainees or faculty members around the country, along with other colleagues, signed a lot of petitions. Hundreds of people signed these, sending it to the chancellor, the chief medical officer, the chair of medicine, the chief nephrologist. And I think that they, at that point, I think had a very specific request, which was actually adopted by many medical centers. This is from the MGH Brigham, where I trained as a nephrologist, in which they would basically drop the race coefficient. So instead of reporting if African American or if not African American, they would just report one number, the one which I think all the examples I know of in the University of Washington, where Susan is, UC Irvine, I believe, where the previous speaker did this, University of down in Vanderbilt and many other places. And I think this generated a lot of controversy, and we actually personally did not agree to do this. I think a lot of our position is a little summed up by this commentary by Neil Poe, who basically points out that by dropping the race coefficient, right, this is basically a dominant race standard, which is you normalization to the majority race group. He points out it's easy to implement because labs simply had to drop the Black person value. However, it ignores the Cranon data on Black persons in equation derivation, effectively removing the Cranon ethnic effect. This approach, if replicated throughout biomedical science, would institutionally exclude Black persons from their data and research. So, before I go on to my paper, any questions from the audience or any chat?
Nothing in the chat, but for me, I think the big one these days, SGLT2 inhibitor usage, they have limited to lower EGFR of 20, I think. Yeah. So if anybody below that, you're not supposed to use it. That's put another disadvantage.
Correct. I think that threshold, as you know, has gone down from 45 to 30. I think Emperor Preserve, I think it was 20. So you're right. Now, so I think that one would
and exclude a lot of chemotherapies for
a lot
patients.
Of chemotherapies, right? So drug dosing. So that is an issue, right? There's a question in the chat. I think we let the social aspect of this discussion precede scientific, the AHA, right? So I think this is an important issue, and I would give you my opinion about the social part of it. I do think the social part of it is clearly important. And I think that our paper hopefully points to a solution that you can have racial justice and be accurate. You can have your cake and eat it too, hopefully, right? And so I think that's a big part of our motivation, right? I think that we certainly, when my colleagues started working on this, we felt uncomfortable with just dropping the race coefficient, which actually was, I would say, and many of you in this audience may know, was the predominant argument about this issue. So the study in question, which again, thank you for the NKF for allowing us to present this, right, is based on the CRIC study. The CRIC study is a chronic insufficiency cohort study. It's a large multi-center NIH study of CKD. Kind of like the renal Framingham, I think it's been told. It's been going on for about 20 years now. It started, it still is actually centered around 7 major clinical centers around the country. UCSF and Kaiser is one. Actually, Kaiser is a lead center. We initially recruited 3939 adults, age 21 to 74, half of whom had diabetes and half of whom were women. It was very good representation of African American study participants, 45%, and initial EGFR was 20 to 7. So in order to be in our study, one had to have a GFR measured at baseline by alpha-thalamate. The alpha-thalamate GFR was purposely not done for everybody. It was a weighted sample of study participants. And then in order to do our study, you had to have a GFR measured, you had to have 24-hour urine creatinine, which I'll get to. You had to have genetic ancestry, and you had to have cystatin C. And that brought us to 1248. It's not the biggest study in the world, but it's still quite large. And I think it's mostly characterized by the richness of the data, right? It's unusual. And I think that's why our study made a valuable contribution, is that you have a cohort that you have GWAS data done, so you could define percent African ancestry. We also had measured GFR, which is unusual. We have very careful measurements of body composition and muscle mass being believed to be a major predictor of creatinine production. We also had dietary protein intake, again, with this idea that meat intake can affect creatinine production. We had a 24-hour urine creatinine excretion, which talks about production as well as extrarenal elimination, for example, in the form of gut clearance. And tubular secretion of creatinine, because the difference between creatinine clearance and GFR. So I see another question, which I will get to, right? So this is our study characteristic. We have 458 Black participants and 790 white participants. They were fairly well matched with regard to, age. This was not by design. Percent male was about half. The non-Black study participants, we purposely included some Asians because the way the equation was phrased is Black and non-Black, right? So we purposely try to mimic that by including some study participants who are not Black otherwise. 21% were Hispanic ethnicity. The percent African genetic ancestry was as predicted. It was very high among those who self-identify as being Black with this range and median, and was very low among those who did not self-identify as being Black. It is well known that European genetic ancestry and mixture is common among those African Americans in this country, and among the non-Black, these are the corresponding numbers. Interestingly, the measured GFR is very similar, 48 versus 39. This is again, sort of by design, although we didn't explicitly go and do this. Creatinine, however, is higher among those who are African American. Cystatin C is the same. 24-hour urine creatinine was higher. Creatinine clearance was the same. Creatinine clearance to IGFR ratio was the same. Creatinine clearance minus IGFR, another measure of creatinine secretion, was the same. Urine protein was not different. Fat-free mass was higher among those who self-identify as African American. BMI was higher, and dietary protein intake actually was, if anything, lower. So we basically asked 3 questions in this study because we wanted to get rid of race if possible. I think we agree with the concern, the criticism of this approach, but we wanted to get rid of it in hopefully a better way than just dropping the race coefficient. So the first question we asked, is it possible to estimate GFR just as well using genetically defined ancestry instead of self-reported race in adults with mild to moderate chronic kidney disease? This sort of addresses 2 criticisms of the race coefficient. One is that it's dichotomous, right? The criticism also that what do you do with people who are biracial, right? Doesn't handle that. 2, it's known that in many electronic medical records, the race term is unclear who assigned that in some way. Right? My understanding is that in some hospitals, like the VA, instead of spitting out 2 numbers, you actually only get 1 number. They will look at the EMR, determine what your race is, and feed you only 1 number to the doctors. This obviously is kind of problematic if your race is assigned by the emergency room clerk who looks at you, right? So using genetic ancestry sort of gets around this because it's continuous. It's somewhat not dependent on somebody else assigning it, right? So this is the results we have. I want to just skip through a few things quickly. So first of all, if you just have age, sex, and creatinine, and you don't have race, the median bias, which is the IGFR, measured GFR minus eGFR, is positive for African Americans. So you are actually underestimating the measured GFR. This is why there's a race coefficient in MDRD and CKD-MB. If you look at P10, which is, and if you take into account race or African ancestry, this goes away. The confidence interval crosses 0. If you look at P10, which is a measure of accuracy, right? How many percent of people have a eGFR within 10% of measured GFR? Without race, it's 31%. With race, it's high at 42%, and it's the same with ancestry, right? For every 10% increase in high African American ancestry, the IGFR is high by 1.6. If you include race, it's 13.6%. This is sort of our race coefficient in this quick data set. This finding is not actually completely new. There's been 2 previous studies at least which have looked at this issue, whether or not those with higher percent African ancestry have higher serum creatinine. And both of them said, yes, this is a study out of Mount Sinai, which showed that every 10% increase in African ancestry, the serum creatinine is higher by 1% or 0.9%. In a mixed population, African Americans and Hispanic or Latino Americans. This study, however, did not have measured GFR. So they don't know if the higher creatinine represents worse renal function, right? Our study showed that it is not because of worse renal function per higher percent African ancestry. It's another paper out of Cardia by Carmen Peralta a long time ago now, and also Kristen Bibins-Domingo, the new JAMA editor-in-chief. We're going to lose her from UCSF. This one also shows that higher African ancestry was independently associated with elevated creatinine. Right. Again, however, they did not have measured GFR. So they can't distinguish between some sort of creatinine effect, which I think is what it is, or a kidney function sort of effect. Right. So the second way one could get around replacing race is by looking at EGFR, GFR-dependent creatinine production factors, right? Because it's not very practical to go around genotyping everybody to do percent ancestry, right? It's doable. Actually, a geneticist actually proposed that to our chair of medicine several years ago, that everybody who comes to UCSF get GWAS because it's getting much cheaper, and then get the genetic ancestry defined. That was not sort of accepted. And furthermore, I think it runs the risk of somehow making people believe that race is not a social construct, right? I would point out that just because higher percent African ancestry correlates with something doesn't mean it's caused by the genetics, right? Higher percent African ancestry, you have darker skin. People who are darker skin are discriminated against more, for example. So I'm going to be very careful about that. So the other way we thought to get rid of race, which may be more practical than using ancestry, although ancestry works quite well, is that can we look at components of creatinine production, creatinine secretion, or creatinine excretion that explain the difference in serum creatinine levels independent of GFR, i.e. the GFR independent determinants of creatinine? And can these variables be used to attenuate or eliminate the race or ancestry coefficients in GEGFR estimating equations? For example, we saw earlier, right, that African-American study participants in CRIC had higher 24-hour urine creatinine. So when I saw that, I was like, well, that's why there's higher serum creatinine at a given GFR level. Can we use that information? There's also higher BMI, can we use that to replace the race coefficient? And this is what we tried to do, right? So we looked, first of all, at the difference between Blacks and non-Blacks in CRIC, or percent African ancestry. You can infer this from the table I showed earlier, right? African Americans had higher BMI, higher fat-free mass, more creatinine excretion, which is the difference between creatinine production and extrarenal elimination. No difference in tubular secretion of creatinine by either the difference or the ratio, and the dietary protein goes the opposite direction. Very similar trend for African ancestry. Right? These two things are very closely correlated. So if we try to explain this, can we? So this is what happens if you have IGFR, creatinine, age, and sex, and this is the race coefficient, 12.8 in this case, right? If you add in BMI, you actually don't attenuate this at all. If you add in fat-free mass, same thing, right? 12.8, 12.4. If you add in 24-hour urine creatinine, it only goes to 10.7. I actually would have thought this would go to 0, but it didn't. Now, if you throw everything in, the most we have, it's still 8.7, right? There's still a gap there which cannot be explained. And similarly for African ancestry, you see very similar results. Even if you throw everything in, there's still an independent effect of African ancestry. So the third thing we said, well, can we replace cystatin? Can we replace creatinine with cystatin C, right? And the short answer is yes. So if you look at this, right, remember the previous P10, right? Here you can see that adding race and adding ancestry doesn't really change the P10. There's also no difference between IGFR and EGFR. There's no bias when you look at Blacks or non-Blacks for that matter, if you have no race or ancestry. I think our main contribution is to show that ancestry is not needed either when you have cystatin C. So to summarize, right, when using serum creatinine to estimate GFR, incorporating race yields better estimates than omitting race. Incorporating genetic ancestry provided estimates of GFR which are similar to those incorporating self-reported race. 2, CRIC participants who self-identify as Black or had higher percent African ancestry had greater BMI, BSA, height, weight, fat-free mass, and 25 urine excretion. However, inclusion of these factors did not eliminate the bias introduced by eliminating creatinine or genetic ancestry from serum creatinine-based EGFR equations. In contrast, incorporation of race or ancestry was unnecessary when GFR was estimated using cystatin C. A GFR estimated equation using cystatin C, age, and sex performed comparably to an equation using age, creatinine, sex, and race or ancestry. Right? If you look at the P10 values, they're very similar, as well as a number of other metrics we looked at, including precision, accuracy, and stuff. And so using cystatin C, we conclude is a feasible, currently available, and scalable approach, which produce estimates of comparable validity while eliminating the negative consequences of race-based approaches. So I want to thank my colleagues and then move on. But again, I want to stop, any questions there. And
Roy Matthew has a couple comment question in the chat. I think you answered a couple.
So when you say, so the accuracy question is very important. Could you elaborate on that more? And I have a slide about the risk equation actually. And
yeah, no, I think you addressed it. Thank you, Dr. Xu. I think you addressed it in your slides. It actually wasn't your article that I was referring to. It was the Anchor article where they looked at the various reinterpretations of the GFR, removing race, and it showed the variation from the measured GFR when you took the race equation out. And one of the problems I had with a lot of this discussion was, the implication that somehow all of our equations were derived, just arbitrarily. And I appreciate your work and all the others who have shown, who showed that, there was a lot of the reasons why the race at the time was kept in the equations was because of its meaning to the equations, not just arbitrarily saying that this was somehow, and really the bigger question was the social question is why were we using the information differently and not really the validity or the scientific effort that went into the equations. So that's what I was referring to with the accuracy point.
Okay, thank you. I will get to that also in a bit. Any other questions before I move on?
Can I have a question?
Yeah.
Shouldn't we move just in terms of medication dosage, shouldn't we just use Markov graph? Yeah,
I'll get to that too. So good question. Hold that question. All right. So let's talk about this. So I think the context is very important, right? Was a lot of these comments have hinted on some of the context, which I think we should talk about, and I would address directly the Markov question here. So this is, I think, a useful paper, which came out, right when I was finishing fellowship, right? It's like over 20 years ago now. So this is the first study that looked at creatinine distribution in a representative US sample. So NHANES we're now into like NHANES 4+, NHANES is a survey the US government does every, with some periodicity. And then NHANES 3 was done in 1988 to 1994. They basically take a representative sample of the US population, a weighted sample, and they try to say things like, what is the country's obesity rate? What is the country's hypertensive rate, diabetes rate? So they actually measure creatinine in groups of individuals, men and women, in different races. And what they found was that the mean creatinine values were highest in non-Hispanic Blacks and lower in non-Hispanic whites on a global level. And this is some of the important, interesting details. So if you look at serum creatinine level among healthy individuals, in the sense that they don't have diabetes or hypertension, right? And they were pretty young, 20 to 39, right? Where you won't expect a lot of comorbid conditions. If you look at men, for non-Hispanic white, the creatinine is 1.14. For non-Hispanic Black, it's 1.24. For women, it's 0.393 and 0.96, right? So among people who don't have diabetes, who don't have a hypertension, who are pretty young, those who self-identify as African-American have higher serum creatinine. Now, they didn't measure renal function, right? So they can't prove that this is not because there's more kidney disease, among this group of people. But it seems unlikely, right? Because you see this actually also among those who are 12 to 19. So the authors say that we have shown there are ethnic differences in the population distribution. If these differences are caused by differences in muscle mass or renal tubular handling or creatinine, rather than a true difference in GFR, then defining abnormal cutoff values for creatinine based on a population would be wrong. It would not be good, right? Because in African Americans, it might lead to unnecessary further testing, increased expense, and possibly iatrogenic morbidity because of overdiagnosis of renal disease in the non-Hispanic Black population. So back to your question, CJ, right? If you use the Cox-Cox equation, and there is no race correction, and you use creatinine, African American study participants would seem to have lower kidney function, right? Because they will have higher serum creatinine. So that's a problem if you believe, which I think the MDRD, CKD, EPI, and our data show that any given GFR level, African American, those who self-identify as African American, despite all the problems, we completely agree there's a lot of misclassification. There's also the issue of admixture, biracial, nevertheless, this is a very consistent observation, right? So that will be a problem with that, right? That equation, by the way, I have a slide for that at the very end, actually, was made from 249 patients. They were all male and all Caucasian. And by the way, this 0.85 for females comes from a throwaway sentence. Because of different relative amounts of fat and muscle in women, a correction is required. 15% seems appropriate. That's how we have 140 minus H times 0.85 for women. So I would say this is really not a very good basis to dose drugs based on this, right? So it was somewhat arbitrary, I agree. However, having said that, the Cox-Cox equation has several advantages. One, it's actually in the units of mils per minute. The MDRD and CKD equation are mils per minute per 173 meters squared. For drug dosing purposes, it should be mils per minute because that is how drug is cleared, right? Drug is not cleared more if you're a bigger person, right? So if you look at the differential equations, which I got the pharmacy people to help me, strictly speaking, so you're not wrong, right? That Cox-Cox has this theoretical advantage. Cox-Cox has another advantage, which is that the FDA, for many years, told people to dose drugs based on Cox-Cox. Therefore, many drugs were based on that. However, that has many problems. So that is not a good solution either, arguably, right? So I hope that partly answers your question. The problem with using the same cutoff is that you have this phenomenon that the same creatinine means different things. And I goes back to Dr. Right. So this was not to Dr. Roy Matthews. It's not an arbitrary thing that people came up with. Right? On the other hand, though, I think there are several arguments against that. Right? One argument is this one, right? Yes, you gain some accuracy, but look, the estimate sucks anyway. It's very inaccurate, right? So this is the argument against people who said this is scientific. Well, this is what Ash Siegel, he basically said, look, this is from Crick, right? This is the eGFR, this is the measured GFR. At any given eGFR level, let's say 40, the actual GFR is 60 something to 20 something. The estimate really is very poor, right? So even if you add some more noise to it, right? What's the big deal, right? The social question, right? I think the question, Roy, right? It is the social value that we are picking, that accuracy is more important than the harm introduced by having this term, which I think causes people to say, why are Black people different? To make people think that somehow Black race is a biological difference. It is a political decision and a social decision. But I would argue that choosing accuracy as the highest value is also a social decision, right? So I don't think the argument that this is social running over science, to value science the way we do is a social decision, right? It is to some extent a political decision also. So I think this is not an invalid point. My personal view about this is as follows. So first of all, there's several things we have to understand. If you look at assessments of accuracy like P10 or P30, right? What you kind of want is that many things are within the measure, right? So you want group precision and unbiased, right? This is something that's unbiased but not very precise. This is kind of like, and EGFR to some extent, right? All over the map. This is not good, right? It's biased and it's far away, right? This is sort of precise, but it's sort of off, right? So what happens is that GFR, I think, is probably down here, EGFR with the race coefficient. It's unbiased, but it's not very precise. If you drop the race coefficient, you're shifting the African-American estimates off. So whatever degree of imprecision there is, you're adding on top of that a bias because there's a race coefficient there, right? Now you could argue, and I think that is not an invalid argument, that I would accept the error because the social cost is so high. That's a value judgment, right? I would sacrifice some accuracy because accuracy is not the only thing in the world that is important in order to gain some, racial justice to some extent, right? That is a political argument. It is a social argument. I don't think that's a wrong argument. One values these things differently, right? So if you see here, right, basically, this is the measure, right? Basically, if you add race, you have more people within 10% error. But if you look at the P30, it's kind of messy, right? The P30 is 86% of measurements are within 30% if you drop the race term. So you're not losing that much accuracy if you use a less sensitive measure, right? This is the bias. This 3.99, right, is basically this. This is how much you offset it by. But is that worth having this term that so many people find objectionable on moral grounds? That's a moral decision, right? Or the issue of prognosis, I think somebody also mentioned that, right? So the issue is that at any given GFR level, we know that African American, on average in this country, do less well, right? Therefore, this should be somehow accounted for, right? So I think that, to me, conceptually, the way I think about it is that there's two issues here, right? One is that how should we best estimate GFR? And that is presumably by some gold standard like alpha-alpha GFR. Then there's a second question: what is the risk of adverse outcomes at any given level of GFR, which may vary by race, right? And analogy is that we should try to measure blood pressure as accurate as possible. Right? Then we recognize that any given blood pressure level, outcomes vary. This goes back to Roy's point, right? At every given GFR level, this varies. I don't know if this is really how people treat the GFR differently, right? But we know that any given blood pressure level, African Americans in this country have higher rates of kidney failure, have higher rates of heart failure, and other things. That doesn't mean we should add blood pressure to African American, right? I mean, that doesn't make sense, it seems, right? Those are two distinct things. Although in conversation, this often gets muddled, right? And this is the arbitrary point I was coming to. This is an interesting piece, right? So basically, this says that whether patients, right, because there's a whole discussion of reclassification, right? Because the argument is that, well, since they do worse, African-American patients should be assigned or should be given in some way a lower GFR level, because that would give them more access to transplant or more benefits, right? So this is an interesting thought experiment, right? If we imagine not only removing the correction factor, which is a race coefficient, but instead further lowering Black patient EGFR by additional 16%, it will lead to even more Black patients being labeled as having CKD and receiving the benefits thereof, like early access to transplant, seeing a nephrologist, things like that. But I think these people argue that, it doesn't make a lot of sense, right? And I think that's a valid point. There's actually been a lot of bunch of papers about this. Let's say if we remove the race coefficient, how many more Blacks in the VA system or in some hospitals EMR will be classified as stage 4 versus stage 3 or stage 3 versus stage 2, right? There's been several papers of that. That's not of no value, but I think with the implication that that's a good thing. Look, more people are CKD, they're high risk, they should see a nephrologist, right? So I think back to CJ's point, right, about SGLT2 inhibitors, what are the pros and cons of this? This is a paper by Leslie Inker and Andy Levy, the people who came up with the equations, right? Basically, the argument is that if you basically with the race coefficient, if you remove the race coefficient, this is what happens on top to number of people, right? So somebody's GFR would drop from 33 to 28 because you remove the race coefficient. This then results in them not going clinical trials, SGLT2 inhibitors, right? There are problems with that. If they drop from 64 to 55, and this is the actual magnitude of drop, based on a number of patients they have, you would, as you point out, right, get less chemo. You would get less, methotrexate. Maybe, that's not a good thing. And then if you drop from 80 to 71, maybe you'll be screened out for kidney donation, right? Although I don't think people use this entirely to determine donor status, right? So there's a price to be paid, right? And so this is a game from Neil, right? Basically, it lowers, arguably, artificially, the eGFR estimate for Black people. The benefits hoped for might be more aggressive early CKD management, right? That's a big argument, right? Because of worse prognosis. And increased access to specialists and to the transplant wait list, nutritional therapy, CKD education. However, it introduces potential harms of overdiagnosis, anxiety, or financial implications. For example, access to life insurance. Decreasing access to living kidney donation, harming metformin, SGLT2 inhibitors, pain medication. I'm not sure about ACE inhibitors personally, but certainly chemotherapy and antibiotics. And also less contrast imaging, right? Like I showed that at the UCSF data. And I think Neil makes the point that the epidemiology of kidney disease, this would affect a lot of people, right? Because there's a lot of people with stage 2, 3, 3A borderline, whereas the number of people at the other end, on the transplant end, is very small, right? And there's a number of papers suggesting this, right? This goes to your comment, CJ, right? What if we just dose metformin by cohort GALT? Well, that would be basically dosing it largely by creatinine. It used to be that the FDA said don't give metformin if the creatinine is above 1.4 in men and 1.5 in men and 1.4 in women. In 2016, they changed it. So now they use a cutoff of 30. So before the label change, you can see for people with stage 3 ACKD, there's a lower percent prescription in Blacks versus whites. After the label change, this difference attenuated and became no longer statistically significant. They did a control group with like a glyburide, or sulfonylurea, there was no change. So this is a very specific change which reduced racial disparities. If you went back and used the same creatinine cutoff, you may reintroduce disparities, right? And this is the chemo question that you brought up. This is the paper by Tom Nolan's group showing that removing race from the CKD equation will calculate a lower estimated GFR for Black patients and exclude more patients from getting anti-cancer therapy, which could lead to undertreatment, right? This is not a good thing. And now I would say that people who do these, oncologists, don't think about kidney disease all the time. Family practitioner, family medicine nurse practitioners who give metformin don't think about kidney disease all the time. Radiology technicians at UCSF, right, screening people, don't think about GFR. But people who are waiting transplant have a lot of nephrologists and sophisticated people thinking about them. It would seem that we can get around this arbitrary rule more easily than educating all the oncologists in the world, or the endocrinologists, primary care doctors, family medicine people, right? So it is interesting that this has gotten so much attention and was the impetus of so much of the discussion, partly because I think it's very easy, very compelling story and seems really wrong at some level, whereas the other benefits and harms are much more abstract, right? Harder to guess in some sense. So the future, what does the future look like? So I think almost everybody on this phone knows, on this call knows that the NKF and ASN put out a recommendation on September 23rd, the same day that the two papers came out, New England Journal of Medicine, and the primary recommendation was to use the equation without the race variable. And then the second recommendation was to use sentencing more, right? and then to do more research, and that they think this is a very good example of hearing out from the stakeholders, right? Now, I think it's interesting that Roy Matthews talked about accuracy. Okay, this is the paper that Inker, the same people who created the problem, arguably in the first place, by having a race coefficient. Although I agree, when it came out, I think someone like myself, I freely admit, didn't think much about it, right? In statisticals, we always adjust for age, sex, and race anyway, and it's very common. And I don't think that was intrinsically racist in the sense. I don't think Andy Levy and Leslie Inker are. However, I would agree that it is true that if the research team were more diverse, probably people would have questioned that more. That I do believe is true, right? It may still have resulted in this, but I think people would have questioned that more. I don't know that for sure, of course. But look at what this is a table from them, right? So the Black participants are in green. The non-Black participants are this sort of orange color. The line of identity is Black. So if you have the GFR equation with age, sex, and race, the old MDR, the old CKDF equation, it is pretty unbiased in that you fall right on the line of identity, right? The P30 is 85%. It's pretty similar to NCRIC in the 80s, by 30%. But look at the scatter, right? The scatter is exactly the same as what Ash Sego showed in his Adams paper, right? There's so much noise, what's another, imposition. This is what happens when you drop the race and you do the non-Black, if non-Black, right? This is what happens at the Brigham MGH, University of Washington, UC Irvine, Vanderbilt, and many other institutions. You basically, the green line, right? The African-American estimates are now green. The non-Black estimates fall right on the line of identity, right? But at every given GFR level, the actual GFR is higher, right? So at any given actual GFR level, right, the estimates are systematically off, right? This is sort of the problem. And this is the issue about adding bias to the imposition. Now look at the new equation, right? It's interesting, there's a comment that's, this illustrates out. This does not actually solve the problem. The lines have been moved, so now the error is equally spread between Black and non-Black participants. That is more fair in some sense, but this delta has not changed. This gap between the green line and the orange line has not changed because we're using Cranon. And our papers show that it's very hard to get rid of this gap if you're using Cranon. There's something about Cranon, right? So the
Can I ask a quick question?
yes.
It's David Menke.
Yes, David.
Is this new equation, is this just re-looking at old data, or did they do a study and generate their own new
They
data?
basically took the same data they had and just refit the equation, artificially dropping the Black term. They did a few things by varying the percent of African Americans in the study population, modeling it mathematically, and they have more African American studies in the validation data set. But this is largely the same group of people. They were asked to do this by many people, which I do think this is a reasonable compromise. It is more, I think, better than just simply dropping the race coefficient. But this is fundamental. They didn't even change the knots, the structure of the equation, right? And they didn't come up with a new Cranon, this is C one, right? They just did this one. And they previously had a combined equation, you may know, which I personally don't quite know if you have cystatin C, why do you have to have Cranon also? Because you also have this delta. It's a smaller gap, but it's nonetheless a gap. The big advantage here is that not all the error is concentrated in the green line, which is what the people who signed the petition and handed it to the chancellor of UCSF and other healthcare systems were advocating for. What we now do is that the green is wrong, and so is the orange. It's a little more fair in some way, right? But because you're using Cranon, you will always have this problem. So our thinking, based on our paper, is that you should use the cystatin C, which is basically just as good. You can have your cake and eat it too. You don't need race, but you don't sacrifice the accuracy. And so this is what we have now today at UCSF. Actually, we have implemented a race-free GFR equation. So we used to have 2 lines. We have only 1 line now. We've made consistency in-house. And so we have a consistency panel. If you order that, you get all 3. You know, it's, I think, an interesting argument because we're noticing, we're learning that it's different. You know, the readings are all the same. And so now instead of 2 blood tests for kidney function, we have 3: BUN, creatinine, and cystatin C. I think that's an interesting future. Again, I do not own stocks in any company that makes cystatin C. For 20+ years, you know, a lot of class users have been advocating cystatin C, not 20 years, but, you know, 10+ years, and I have not jumped on the wagon. But I think it's not a bad thing that we go beyond creatinine, because there's something about creatinine and race that I just don't think we can overcome. And to the extent that we should get rid of race in estimating GFR, which I think is a good thing, but not sacrifice accuracy, we should just do cystatin C. So I think I would end there. We are right on time, and take questions.
Great, thank you so much. Anybody has any question, feel free to.
It's another quick follow-up question. In the 2 equations, when you go to the newer equation that the task force chose, is the difference in creatinine clearance great enough to affect drug dosing between the 2?
It depends. If you're right at the borderline, yes. These are very arbitrary decisions. As you know, I have patients on metformin and low GFR. The endocrinologist and I give a very low dose. You know, a lot of these things, frankly, are arbitrary, right? As practicing nephrologists know, a lot of it is how are they changing within themselves? Are they progressing? Are they stable? You don't really need to know the absolute GFR in the majority of cases managing patients, frankly. And many of the cases when we do need them are highly man-made situations. We made some rule about 20. We had some enrollment data. Unfortunately, that is how life runs. You can't be thinking about this every single time, right? Blood pressure 140, you treat, you know, cholesterol 200. Life needs these simple cutoffs for medicine to proceed. So yes, I think that, you know, depends on where you are, right? If your GFR is 80, 85, 82, 90 doesn't really matter, right? In many cases, 120, right? Yeah, at some cut points it will matter. So
Maybe we should change the way we think. Life may not need these simple things to proceed. Instead of a simple cutoff, maybe we should just have a range. Metformin, if range between 20 to 40, you can still use it. Refer for transplant if eGFR between 20 to 30, you can still refer instead of just
20?
one number.
You still have a lower bound, right? And if you do that for every single thing, you will go crazy. You're a doctor, you see every patient, 20 minutes a patient. For every single LFT, CBC, you're gonna have that rule, you're gonna be paralyzed. Right? It just doesn't, life doesn't work. I think you're right. If you will have one patient and he was your father or something like that, and you had a good friend, and you can think about it for hours and hours, yeah, sure, I agree. But we do need simple rules, right? Again, who gets a CAT scan? Well, there have to be some simple rules that, again, not to pick on the family medicine MP, maybe someone here, don't mean to pick on it, but somebody needs some very simple rules to operate. I am very simple-minded when it comes to liver function tests, right? Or when it comes to some orthopedic problem, right? You have to be simple-minded to move on. You can't, we think a lot about GFR, other people don't. And we can't have the world thinking so much about GFR. That's a big problem. And it turns out, by the way, at UCSF, the eGFR is the only single blood test in which race enters into it. Interestingly, no other blood test is there such a thing. So I think that has been singled out for good reason. Right?
Great, thank you so much. Anybody has any other questions? If not, we call it a day. Thank you, Chi, and thank you, Susan. Thank you, Dr. Hannah. What another great journal club, and thanks, Patty and Amy. Take care.
Thank you.
Thank you.
Thank you, Dr. Su. Thanks, everyone. Have a good evening.